Thank you very much for our speakers. Excellent topics, excellent talks. I'd ask the attendees and participants to post their questions in the Q&A section so we can ask our speakers. I have a question for Dr. Spears. In acute tandem occlusion in stroke patients, what's your approach, or what's your institution approach to stenting in tandem occlusions when needed? Do you do antegrade or retrograde approach?
Can you see me or hear me?
Yes, yes, we can.
So for an acute stroke or for a tandem, like a carotid cavernous segment and a extracranial carotid?
Acute tandem occlusions in acute ischemic.
Yeah. We try and get away without leaving a stent behind. We cross, we go above, we open it up, and then we come back down and have a look and see if it's open. If we can avoid the dual platelets up front, we try to, but sometimes our hand is forced. So usually we go upstairs, open it up, come back down, and see if we can get away without a stent. Sometimes we can't, but that would be the typical first choice.
Mm-hmm. Great, excellent. I have a second question for in patients with acute dissection. What's the role of stenting in acute or chronic pseudoaneurysms of the distal carotid, distal cervical carotid?
That's again for me. So in general, extracranial carotid dissections are first go medical management. Refractoriness, so recurrent documented clinical or radiographic ischemia after failed medical therapy, which we usually define at least dual antiplatelet or anticoagulation, we would consider repairing. But I must say the incidence or the utilization of stenting for acute carotid dissections is very low in our institution, and we haven't had too many difficulties. Now, I did have a question actually, and when it's my turn, I have one for Dr. Aldakkan about a case, but I'll wait till that moment.
Okay. The last question for you, Dr. Spears, is might be technical, and in chronic dissections, when there is a pseudoaneurysm and there is an indication to either stent or prepare surgically, if you decide to stent the pseudoaneurysm, what's your choice of stenting? Do you go with the regular stenting or you use flow diverter stents?
So this is extracranial again?
Yes, extracranial.
In general, the majority of extracranial carotid dissection pseudoaneurysms are managed medically. If there's evidence of growth, we've had probably a handful where we've had great controversy, conference them with our vascular colleagues, and the majority of the time they actually don't get repaired with stenting. If they, however, were having a growing pseudoaneurysm with recurrent embolic phenomenon on anticoagulation, we would probably use a covered stent in general terms. But I must say the treatment of a extracranial carotid dissecting pseudoaneurysm in and of itself usually gets serial observation. They stabilize within 6 to 12 months and they simply are observed. We have a handful of cases where we have a large palpable mass, and those pseudoaneurysms, there was 1 or 2 that were post surgical traumatic from neck surgery or post-endarterectomy, but the vast majority of the spontaneous ones are managed medically. But if we needed to repair, we typically would go to a covered stent.
Okay, great. Thank you very much, Dr. Spears.
Yeah, you're welcome.
Maybe this question is for Dr. Musaad. In occluded internal carotid arteries, what's your approach to revascularization? Would you in interventional, the way we think is when it's closed and there is no hypoperfusion problems, we keep it closed. But let's say we have a patient who has an occluded ICA with hypoperfusion. What's the role of revascularization, either with endarterectomy or shunting?
Dr. Musaad, you're muted, I think, so you need to unmute, please.
I'm sorry. Do you hear me now?
Yes.
Yeah. So that's a good question. In general, as you mentioned, if the carotid artery is documented to have an occlusion, and we sometimes see these patients where they present with a TIA or a stroke, they get triaged for a code stroke, they get imaged, and they have an occlusion, complete occlusion. The management for that is essentially medical. Even if there is a deficit or a hypoperfusion from our end, I think it's the benefit of actually trying to revascularize that is a lot less, I would think, than trying to revascularize it, and that would lead to the hypoperfusion as well, especially if there's a contralateral lesion. The sticking point comes when there is there's a documented occlusion, yet a patient presents a couple weeks, couple days, couple months later with another symptoms of the same side. That becomes a bit of a dilemma that you have to really reevaluate this first to make sure it's occluded, because sometimes the imaging modalities differ. And that's one of the points where you have to do an actual angiogram to make sure it's occluded. And if it is, then you're left with two things: whether you have again, the theories of a carotid stump syndrome, where the back end of the occlusion of the plaque or thrombus, at some thrombus that actually goes up, breaks off and goes up and causes the symptoms, where you have to, what we do with that is basically go in and ligate the internal carotid artery distally. The other potential cause of that is when these are coming from the external carotid artery back into the internal, where there's a little bit of a channel in there, and some folks actually advocate for doing an endarterectomy for the external itself and just leave the internal alone, with ligation to just reestablish the flow to the external. But I think that the question that comes to mind with a documented occlusion followed by an event is to actually reevaluate and ensure that that artery is actually occluded. And we've had a few cases here and also in Toronto, in multiple sites, where the patient had, say, a CT or an MR or even a duplex saying that there's an occlusion, yet they present with another event and they reopen. It's very rare to reopen spontaneously, but when it reopens, essentially becomes a symptomatic carotid disease that needs to be treated as such.
Great, thank you very much. There is a question from the attendees: is how do you deal with bilateral severe carotid stenosis?
I'll deal with the symptomatic one. The question is for me: if the patient is presenting with symptoms, then I'll deal with the symptomatic one. If the patient is asymptomatic, and that's I'm still starting to practice. I'm still worried about the asymptomatic patients, and I'm still actually unsure when to get into those and operate on them. Obviously, a shared decision making with the patient when it comes to an asymptomatic disease is important. I've had to operate on someone a couple weeks ago because they kept coming back to clinic saying, I cannot sleep at night because I'm worried I'm going to get a stroke at some point. And they're a 62 years old smoker who's stopping smoking and starting to run 3 miles a day, worried about this. And I think, you just present them with the evidence and saying that the stroke risk, the perioperative stroke risk, is actually higher than having a stroke in the next 3 or 5 years. If they accept that, then I think that's reasonable to intervene at that point. But an asymptomatic patient without anything, I think CREST-2 trial is the best venue to answer this question, and I hope it does soon. Great,
thank you very much, Dr. Musaad. This question maybe for Dr. Abdulrahman Aldakkan is for post-revascularization. What's your approach? Do you use antiplatelets? For how long? And any preference for ticagrelor or over clopidogrel or aspirin only? So what's your approach, Dr. Aldakkan?
Yes, thank you. In general, it depends on what was the revascularization method done. I mean, if it's surgical, typically would give the patient an aspirin if it's some sort of a bypass or something. But the most common procedure, as we all know, is probably endovascular repair. what we tend to do when I was training in Toronto is that for intracranial stenting, we switch from dual antiplatelet, aspirin Plavix, to ticagrelor and aspirin for 3 months, and then we'll stop the one agent and then continue on the other. Typically, the concept of the antiplatelet therapy after stenting is you're waiting for the neo-endothelialization, or the endothelium to cover the stent from the inside. And when that happens, the risk of thrombotic event goes lower. And this typically takes 3 to 6 months. So the duration is around 3 to 6 months. The agent, it depends. I don't think there is a clear guideline, but typically for extracranial one, we'd use aspirin Plavix, and for intracranial disease, we'll probably use ticagrelor.
Okay, great. Thank you very much. I'll leave the last question for Dr. Spears. So please, Dr. Spears, go ahead.
Oh, I have a case that just came that struggling with. It's a 23-year-old woman who has had 3 recurrent carotid dissections. She does not have a proven collagen vascular disease, but it's obviously a consideration. No stigmata in the rest of the body. And she's had 3 carotid dissections. The last one, which she's got an occluded carotid, but all the other 2 were occluded and they reopened. And she each time has a small ischemic event with mild neurological deficit. So the question is, she was managed with maximal medical therapy, 3 dissections, all small little strokes, dominant hemisphere, no proven collagen vascular disease, but suspicious. Should we prophylactically repair that carotid artery to prevent the 4th dissection? And you can choose with a stent or however you choose to do it, but I don't know what to do.
So just a question, I'm not sure what to do as well. It's a challenging case, but is all the dissections in the same vessel, like in the same?
Correct.
Close locations?
Close to one another, all in the same neighborhood.
Okay, so maybe that dissection never healed from the beginning. I mean, the case that I showed from that OCT basically showed an intimal flap that was way proximal than the intimal flap that was close to the pseudoaneurysm. So if she was on best medical management, that's something to consider. I'm not sure if doing an OCT just for the sake of interest, just to see. I mean, if
so the question is when? It's occluded right now.
It's closed.
Yeah.
Okay, if it's closed, I wouldn't do anything. I would wait.
Okay, so then it reopens in say a month and a half.
Yes.
She's fine, she's recovered, and it's reopening.
If it's reopening, I'll probably counsel for intervention. That's the 3rd event.
You'd fix it? Yeah.
I would counsel, yeah. I would offer it. I would explain everything, but if it happens 3 times, and each time with an event, the 4th time might be a disabling one. So I think it's very reasonable to consider intervening.
Well, I've just met her. I wasn't involved in her first 3 events. If it reopens, I'll call you and you can tell me how I should do it.
She doesn't have collagen vascular disease. Does she have FMD?
She doesn't have stigmata of FMD. Obviously, collagen vascular disease high on the differential, but there's no additional stigmata of that at this point. But obviously, genetic testing and extensive evaluation because it's highly suspicious.
Are you guys? I mean, I don't think you guys had it before, but are you guys rich enough now to have IVUS? Because I think IVUS might be very helpful.
Yeah. We don't use it routinely.
Yeah. Well, tough case. I'm glad I'm not there. In good hands.
Well, we'll see what happens. Keep you posted.
So what about the ulcerating plaque or fatty plaque that's less than 50%, but it looks like an embolic stroke? Do you fix those or best medical management? I want to hear what the panelist would do for that.
So when I first started practice, I received a couple of those referrals for 40% ulcerated with the TIA. Luckily, they weren't optimized medically. So I had a way out. But someone who's maximally medically treated with an ulcerated plaque at 40%, for what it's worth, we would do vessel wall imaging. I would still say that it's experimental, but nonetheless, I would do it for completeness and demonstration of thoroughness. And I would consider, in a satisfactory patient, putting a stent in. Because I think degree of stenosis, not completely, but in a sense, is a surrogate for plaque instability and plaque turbulence. So I think the principles apply, recognizing the shortcomings of the two-dimensional imaging era.
And what type of stenting would you use, Dr. Spears?
We probably wouldn't dilate. We'd probably use a protege. 10/40 would be typical, and just lay it in and leave it at that. Probably no dilation. We'd use distal protection. Yeah. I do have, I'll let the other panelists, but I'll have one more question after.
I think from my end, there actually has been some reports recently published about treatment of patients with less than 50%, whether symptomatic or asymptomatic, and especially the symptomatic ones, raising the question of the accuracy of measurement of diameter reduction or stenosis. And I think the first thing to suggest is that please reconfirm, re-examine this with a duplex, with a CT, with an MR, or even with an angiography, and try to determine that. And as I mentioned, one of the limitations of the NASA criteria is that if the bulb is large, with a large burden of thrombus, it may underestimate the stenosis, and you may have to use the ECSD criteria to show you that. And if the patient is having if the patient is having symptoms presenting with a TIA or a stroke, I think by no means there is no harm in discussing this with the patient and even offering an intervention, because it's only a matter of time. If the TIA happens, it's a matter of time before a disabling stroke kicks in. But I think documenting and making sure the degree of stenosis is accurate is the first step in that.
I just had a comment that I know I'm in North America right now and you're at home, but to hear someone put in a presentation that the neurosurgeons are the good guys, really, maybe you could share that slide with the rest of Toronto.
I mean, Abdulrahman's office is right next door, so I'm clearly scared of that, so we just be careful.
I need a screenshot of that.
It was nice seeing you again, Dr. Spears, and I hope everyone up there in the GTA is hopefully safe. We're just hearing the horrible news of COVID. I hope everyone listening is safe and getting to safety hopefully soon. We're hoping to get this back in our rear end, like a rear mirror, a really long time ago. But I think what's happening now in Toronto and Ontario in general is just very, very disheartening. And everybody's impacted by it. We're actually getting another wave, and vaccinate. If you can get the shot, just get the shot.
That's right. Agree totally. Well, thanks for allowing me to participate with such an esteemed group on the panel. So thanks again.
Thank you very much.
Thank you all for all the attendees and the panelists, and see you again. Our next event hopefully is going to be in May. We have a free registration, so join us, and stay safe, everyone. And good evening, good afternoon.
Fantastic.
Thank you very much, Dr.